Good evening, everyone. Thank you for joining us. Our webinar is Applying the SIBO Test in Clinical Practice. Our speaker is our Dr. Wayne Sedano, Director of Clinical Support and Education for Evexia Diagnostics. My name is Michelle Holmes. I'm the Director of Client Relations for Evexia Diagnostics and will be your moderator for this evening. Dr. Sedano is a chiropractic physician, a diplomate of the American Board of Chiropractic Internists, a diplomate of the American Clinical Board of Nutrition, a certified functional and integrative medicine practitioner, and is board certified in traditional naturopathy. After graduating from Texas Chiropractic College and Rutgers University in the late 1980s, Dr. Sedano began treating patients in private practice while continuing postgraduate studies through Logan College, Townsend State University, and the Institute for Functional Medicine. In 2005, his focus shifted toward teaching for the American Board of Chiropractic Internists, which led to his dedication to research and development in the areas of integrative and functional medicine, and lecturing for a number of organizations within this healthcare arena. Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teachers internationally. Before we begin, I would like to encourage all participants to send any questions you may have during the webinar. Please type your questions into either the chat or question box and send to organizer. We will respond to those questions before the end of the presentation and will allow extra time if needed. A common question is where you can find the recording of this webinar. I will send you a link tomorrow, and it will also be available on our website. You will find it by logging into your account and going to Client Services. If you are not already a client, please go to our website, www.evexiadiagnostics.com, and click on Become a Client to join us. I will now turn over the presentation to Dr. Sedano.
Thank you very much, Michelle. Good evening, everyone. And as you can see on the slide, we're going to be talking about small intestine bacterial overgrowth and how to apply the test in clinical practice. So let's get started. There we go. So the first thing I want to do is define SIBO. So what is SIBO? What is this small intestinal bacterial overgrowth, also known as bacterial overgrowth of the small intestine, as you see on the top? Well, essentially what that is it reads on the slide, it's abnormal colonization of the small bowel by bacteria that's normally found in the colon or in the mouth or in the pharynx. And I have on the slide listed the type of bacteria that's commonly found or associated with SIBO. And as you can see, there's commensal anaerobics and commensal aerobic bacteria. Now, just to list those out, the commensal anaerobic would be the Bacteroides, Clostridium, and Lactobacillus. And the common commensal aerobes, Streptococcus, you see E. coli there, Klebsiella, and on the bottom, more recently found is Proteus mirabilis and also Enterococcus. So those are the ones that really create most of the problem with the overgrowth of bacteria in the small intestine. So this slide lists factors that control the number and amount of bacteria in the small intestine. In other words, if gastric secretions are off, if intestinal peristalsis is off, meaning either through something called gastroparesis, and I'll mention that on an upcoming slide, or constipation or so forth, that is going to cause more colonization in the small intestine. Now, of course, pancreatic secretions, if the pancreas isn't working properly, if there's a problem with the ileocecal valve function, problem with bile salts, meaning that there is problem with existing gallbladder problems, gallstones, things of that nature, and if there's alteration in the pH of the lumen. All of that is going to lead to potentially increased bacteria in the small intestine. And remember, as it's underscored on the slide, that bacteria ferment carbohydrates. That's all the gas and bloating that your patients will complain of and just flat out not feeling right in regards to the GI system. So let's go over some of the general indicators on this slide, and I'm going to go over some specific ones on the next slide and risk factors as well. So just sit back and kind of enjoy and think about your patient coming in on their patient history. These are going to give you clues, the general indicators. First, very obvious gas, bloating, or diarrhea, usually after a meal. Patient presents with that on the patient history. That puts that in potential for suspected SIBO. Unexplained weight loss, that would be caused by malabsorption. Remember, early stages of diabetes are going to do that as well. If there's already existing evidence of malabsorption, chronic hypochlorhydria or achlorhydria, particularly in the older individual, if there's low acid in the stomach that is not able to kill off bacteria that is, say, on the foods, it can get into the small intestine because the acid is just not there to sterilize the food before it gets to the small intestine. And of course, one of the biggies, how many people are using acid blocking medication that will increase the pH of the stomach, allowing just about anything to get through in regard to bacteria-wise, where it can end up. You hear about these bouts of E. coli. I think there was a latest problem with romaine lettuce not too long ago in the U.S. with bacteria being on that causing illness. And I believe that if people have the proper amount of acid being secreted in the stomach, it should handle a lot of these things that are exposed, the bacteria that we're exposed to, say, on salad bars and so forth. If there's a history of prior intestinal surgery or chronic constipation, certainly that's going to be suspicious for SIBO, meaning that there is lower movement of or transit time of food laying in the gut as well as bacteria. If there's a problem or existing problem, say, with lactose intolerance, meaning intolerance of the disaccharides, and lactose obviously is a disaccharide, again, another suspicion for that, for SIBO. If there's unexplained B12 deficiency, if there are other nutrients that become deficient, say calcium, magnesium, or fat-soluble vitamins, that's pretty much going to tell you need to check the GI system out. There's some malabsorption going on with that individual, or perhaps with the diet or a combination of both. And certainly if there's unexplained increased intestinal permeability, all of those are general indicators as you put your patient's story together during the patient history. Now, so this is a list of specific indicators for SIBO. In other words, if these are positive on your patient history, it's a high probability you need to check for SIBO and do this test, and probably pair it with a stool analysis as well, which I think is kind of the best combination, but I'll get into that a little later on this slide presentation. So let's go slowly over the bullets. So if a patient develops irritable bowel syndrome following, that should be a bout of acute gastroenteritis, meaning that they had an infection and all of a sudden they get irritable bowel syndrome, which is very common, by the way. Say someone goes overseas and they get a bacteria in the gut, and they say, you know what, I really just never got over that. I was treated with antibiotics, natural or pharmaceutical, but I just really never got over that. That's very high suspicion for SIBO creating this inflammatory bowel disease. And if a patient reports dramatic transient improvement, meaning temporary improvement, if they're given antibiotic treatment, right? What happens is if the patient says, you know what, I felt better. I had a cold or a flu, and I wound up getting some antibiotics, natural or pharmaceutical. You know what, my stomach started feeling a little bit better. There's your sign. Because what happened is that the antibiotics, the natural pharmaceutical, they knock the overgrowth down, albeit temporarily. But if they could say that, you know what, they felt a little bit better, there's your suspicion, very specific indicator for SIBO. Another one is that the next bullet, that if a patient reports worsening of SIBO from ingesting probiotics that contain prebiotics. Now, what are prebiotics? Those are the food or the carbohydrates that the probiotics live off of. So now, if there's a lot of prebiotics, or you're prescribing prebiotics, and the patient complains that their IBS is getting worse, SIBO is very high on that list as well. And of course, the patient reports eating more fiber increases constipation or other IBS symptoms. We want to prescribe fiber in the correct amount for our patients, but if they complain, you know, I'm getting worse since you prescribed me, just prescribed fiber for me to get my bowels moving a little bit better, there's your sign to order this test as well, or suspect or look for SIBO as well. Celiac is an interesting one. Next bullet down. A celiac patient, if they report insufficient improvement in digestive symptoms, even after they're on the diet, and they stuck to the diet, SIBO, again, is very high on the list for suspicion. Next bullet down, patient develops constipation-type IBS. Of course, there's IBS-D, diarrhea, IBS-C for constipation after they take opioids, because what do opioids do? They slow down the bowel function. And if there's chronic low ferritin, that's a storage form of iron, for no reason, this could be contributed to that as well. And of course, if you have the benefit of abdominal imaging studies where you see a large accumulation of gas obscuring the pancreas, certainly over gas production, hydrogen and methane gas is certainly an indication, a specific indicator for SIBO as well in the gut. So now I want to talk about the risk factors. And so again, we're back looking at patient history as well, and I have these broken down on 2 slides. First is, again, motility disorders. Things are not moving properly. The first one on the top is called gastroparesis. Think of that as a problem with just like a diabetic neuropathy, when these patients get a nerve damage due to diabetes causing oxidative stress and damaging the nerves. Can be very susceptible, and of course the nerve going to the stomach is the vagus nerve as well. Well, if there's gastroparesis, which essentially means that the stomach muscles are not working properly to help grind and digest some of the food, that's a disorder of motility, a very high risk factor for SIBO. Of course, GERD, and you see the list down there: small bowel dysmobility. One I want to talk about here is this dysautonomia. That is a neurological condition, and that condition itself, think of that as a autonomic nervous system dysfunction. And if you have patients that have problems with autonomic nervous system, and that could be adrenal stress problems, there could be problems, and I believe from a functional medicine perspective, pesticides, that because these are neurotoxins, can create this as well. So you might want to keep an eye out for that as well. Of course, liver problems and scleroderma is another one. All those will cause motility disorders. The food is not moving through the bowel properly, and not having regular bowel movements, creating this perfect storm for risk factors for SIBO. Next on the list here is the structural and anatomic conditions. As you can see, what that means is very slow transit time, and there's your list of things that can do that. Some of it's going to be repeated, but if there's a small intestine diverticula or diverticulosis, now diverticula is an outpocketing of the bowel itself, where food can lay in there, bacteria can lay in there. Usually there's been some ongoing constipation to create this kind of problem. You can also get that in the large intestine as well. If there's strictures from radiation or certain medications, some inflammatory bowel disease can do that, and certainly some surgeries, resection of the ileocecal valve. There's a fistula proximal and distal to the bowel, and certainly gastric resection. That was going to cause a structural and anatomical conditions that is going to slow transient time, allowing for this condition in the small intestine. Now, a few more risk factors. I mentioned hypochlorhydria, and there's going to be a little repeat here, but what can cause hypochlorhydria? One is certainly age can do that with elderly patients. They're not making enough hydrochloric acid to help digest food, and also a first line of defense to kill any bacteria and parasites and fungus that are laying on the food. If your patient comes in with a history of chronic H. pylori infection, certainly that's high on the list. That can create hypochlorhydria, damaging the intestinal lining. Antacid use, you see there, hypothyroidism, gastric bypass surgery. And I want to mention some of these medications that your patients and our patients are taking. The use of H2 inhibitors, essentially that refers to histamine 2 receptor antagonists. The medications I'm talking about are Pepcid, Tagamet, and Zantac are those. And then you have these proton pump inhibitors that stops hydrochloric acid from being produced. You're probably familiar with these: Prilosec, Nexium, and Prevacid, and what's the other one I'm thinking? Oh, Acetec, that's another one. If you have, again, we're back to the patient history for these risk factors. Next, medications, antibiotics and acid suppressants. These patients are taking those if there's recurrent use of antibiotics, and that can set up a resistant organisms. There's an interesting thing about bacteria. They have a thing called an efflux potential. Now, what that means is if some bacteria, they're exposed to pharmaceutical antibiotics or something, but they have the ability to, as the antibiotic gets in there, to actually excrete it and become resistant to it. So it's kind of interesting. That's where some natural medications do not get excreted as much as pharmaceuticals from these little bacteria. So another plug for integrative and functional medicine for natural antibiotics. And finally, on the bottom here, organ system dysfunction as it relates to the risk factors for SIBO. Chronic pancreatitis, Crohn's disease, celiac disease, malabsorption, and alcohol abuse. Certainly all of those can set the perfect storm for SIBO. Oh, here we go. So now that I mentioned all that, let's talk about some testing. Let's talk about these breath tests. So what are we looking for in these breath tests? We're looking for hydrogen, which is H2, and methane, CH4 breath test. And here's the take home with the breath test. they represent, like it says here on the slide, a valid and non-invasive diagnostic tool for many gastroenterological conditions. And here's how it works, and here's the rationale, because you need to know how these tests work. It's important. So these hydrogen and also methane breath tests, the concept is that part of the gas is produced by colonic bacteria. And remember, colonic bacteria can work its way into the small intestine, and then that gas diffuses into the blood, then it's excreted by the breath, and then it can be analyzed. This is where the breath tests come in. So here you have where the most useful diagnostic tests, the breath tests that are most frequently used to diagnose. I just have them listed out for you. You can diagnose problems with lactose, sorbitol, and also fructose malabsorption, by the way. It's not only for bacterial overgrowth for breath tests, just to make you aware of that. Now, lactulose, that's that disaccharide. If you hear noise, it's thundering and lightning pretty bad here at home in northern Maryland. The lactulose breath test, that's the one that is pretty specific for small intestinal bacterial overgrowth. I'll get into that in detail. But this test also, as it says on the bottom bullet here, can give you an idea of this oral cecal transit time. In other words, how fast or how slow is food moving through the gut? How is the gut motility? So it's kind of a twofer there, doing the lactulose breath test. Okay, so before I do that, looking at the lactulose breath test, I just want to talk about the glucose breath test just for a few minutes, because that was used at one time for SIBO, and you may be aware that you may see it in the literature. So I thought, it's worth having a look at it just firsthand. And I don't suggest doing the glucose breath test for SIBO, but I just want to make you aware in the literature of what that one is all about, just so you can be a discerning clinician here. So we look over at the description. It says here, of course, under physiological conditions, glucose is absorbed by the small intestine. But if there's bacterial overgrowth in the small intestine, like we've been talking about, the bacteria, they're going to ferment glucose, and that's going to lead to production of hydrogen gas prior to the glucose being absorbed. And what they said was positive for SIBO at the time is that any increase of 10 parts per million of hydrogen or methane concentration in 2 readings is significant for SIBO. Here's the problem with glucose on the bottom paragraph here. Glucose is absorbed within the first 3 feet of the small intestine. So it reflects overgrowth potentially of only the upper part of the small intestine. So that's a disadvantage because you got another 17 feet to go. So that's why you don't want to use glucose. But I just really want to just mention that just to clear that up in your mind, because you may see that in the literature. So now here's the test that we're going to be mainly talking about tonight. That's the use of lactulose. Now, lactulose is a disaccharide, just like it says there, but it's important to know that there is no lactulose enzyme in the small intestine to hydrolyze the sugar. So that's huge, because basically that means it's the bacteria working on this. And this lactulose generally is not absorbed. Potentially it may be into the gut if there is increased permeability, hyperpermeability, but that's another subject here. But the main thing here to keep in mind is that, so the bacteria, they will digest the lactulose, and the end product is what? It's hydrogen gas and methane. And the time interval between ingesting the lactulose and the rise in both of those gases concentration, if it gets over 10 parts per million in two consecutive readings, that's an indication of problems with transient time. And the thing that we're looking for is the bacterial overgrowth of the small intestine, or bacteria migrating again from the large intestine to the small intestine. That can cause bacterial enzymes to digest that lactulose, causing that production of hydrogen and methane gas. That's usually the course of action here of what creates a lot of SIBO. It's that back migration of the large intestine going into the small intestine. Of course, you can get it the other way as well. So that's the take home there. Now, the limitations, there's limitations, and with all tests, please be aware of that. That's where your patient history really rules, and you're using these tests as a major guide, but you always want to put the two together. So here are some of the limitations, so you're aware of those as I proceed to talk about the test. Now, first is there could be carbohydrate malabsorption. That could give you a false positive, so be aware of that. If the patient is not adhering to a low-fiber diet prior to testing, and I'll talk about patient preparation, which has to be done pretty stringently, and I'll outline the details for you. If there's a patient who's on antibiotic therapy, and that is natural or pharmaceutical, it's going to interfere with the test results. And the test should be performed at least 4 weeks post-antibiotic therapy. So it doesn't interfere with the test results. And again, if the patient is on laxative or enema, that can interfere with the test as well. So I just want to give you some of the limitations before we get into the test. So, and the other recommendation, so if you have a patient with IBS, right, these breath tests can also be useful in evaluating diarrhea, constipation, functional bloating, and suspected malabsorption. So this is a wonderful test for those, not only for SIBO, but these other functional conditions. So the breath test, you want a test that analyzes both hydrogen and methane gas. Main reason is because it's been shown to be, it's better to look at both of those gases than just one for carbohydrate malabsorption and also for the diagnosis of SIBO. Bottom line in, these breath tests are non-invasive, they're simple, they're safe alternatives, and I'll talk a little later about the procedures for obtaining the endoscopy procedure in a following slide to look at cultures and look at the aspirate and then culture that, or by biopsy, where that may not be the best test for SIBO, and I'll mention that in upcoming slides, so just keep that in the back of your mind. So patient prep. So when you order one of these tests, here's what you have to remember. You really need to reinforce patient preparation. It is a home kit. The patient will be breathing into these containers. And here's the preparation. I just want to review this with you to make sure you review that with your patient. Just take your time or have someone in your office do that. 2 to 4 weeks from colonoscopy or barium enema. 2 weeks from antibiotics. Could be even more, even fungal, and also Pepto-Bismol, by the way. You can have your patient avoid laxatives and antacids and bulking agents. Now, there is a 24-hour preparation. Again, all the instructions come with the kit, so where you can get these slides, but I definitely read the instructions, have more detail comes with the kit. No probiotics. There's also a list of food that they need to stay away from. At 12 hours prior to testing, there is a fast, only water and only essential medications, no supplements, no gum chewing and no mouthwash, and then 1 hour before the test, no smoking, don't fall asleep, and no vigorous exercise. They need to follow all of these so you can get a successful test result on your patient. Again, it is in the brochure with the kit, but I really suggest you reviewing that when you order these kits so you have it hands down. You can have someone from your staff talk to your patient because you want to make sure the test preparation is done properly because you're going to get strange results if you don't. So now the laboratory assessment of SIBO includes that endoscopy that I mentioned before, and also breath testing. And here's the thing on the endoscopy, so you're aware of that. One, they stick a tube down the throat and get into the small intestine, and they get some aspirate, and then they're going to try to culture that. And here's the thing: it's very sensitive for SIBO, but it has low specificity, lots of false negatives. The reason being is because the aspirate is only taken from one area of the small intestine. So if that's not where most of the bacteria is colonized, that's where you're going to get a lot of false negatives. This is why the breath test is a great test. It has good sensitivity, a lot of low false positives, and overall it's the preferred diagnostic test for SIBO, and it's non-invasive. So that's pretty cool. And this test here does the hydrogen and methane, which is the preferred gases, the combination of those gases, to test for SIBO. Now, there's 2 tests to do. There's a 2-hour test and a 3-hour test, and I'll be showing you samples of that. The 3-hour test, if you choose to do that one, here's the reason for doing that over time, and that's because if the individual presents, again, patient history, with a slower gastrointestinal transit time, or if they have constipation, go for the 3-hour test. You need to extend that out. If everything seems to be okay as far as transit, the 2-hour test should be fine. But always consult with your notes and your patient history. So let's take a look at a sample test that you would get back. So we'll take our time. Here's the chart. Here's the concentration in parts per million. All right, here are the specimens, sample 1, 2, 3, 4, 5, and 6. And this is the 2-hour. Right here in blue is the hydrogen, right here, gas results. And in the black is the methane gas. So you'll see this chart in your results. And then you'll see the table down below. Now the table indicates hydrogen, methane, and carbon dioxide, which I'll talk about of why carbon dioxide is also taken. So we're going to look over here on the bottom first. This is the actual time. These are times the patient reported. They'll log those onto the table, and then the interval between the samples, 0 minutes, 20 minutes, 40 minutes, 60 minutes, 90 minutes, and of course 120 minutes. And then they'll log the samples. Now the thing of interest is over here on the right. Let's talk about evaluation for hydrogen, and we'll read this together here. Hydrogen increased over baseline by 90 minutes. So here's baseline right here. Right, there's 90 minutes is right here at sample 5, and what this is saying, if there is an increase of greater than 20 parts per million, in this case it's 6, so it's actually normal. But if there's an increase over that 90-minute span of greater than 20 parts per million, that is a positive test for hydrogen. Now methane, which is right here, methane is a little different when you look at that. The methane here, evaluation for methane, it's peak methane at any point compared to the baseline. If it raises 10 parts per million at any point in time from baseline, it's a positive result. So let's take a look over here. Here is, of course, methane. Here's baseline. It was measured at 44 parts per million, and sample 4, which is here, okay, measured at 57. Now, subtracting the latter from the former, that's a raise of 13 parts per million. That's why this is high right here, and that's why it's positive. I want to talk also on this test. You're going to see that they're going to give you a calculation of methane and hydrogen gas, and you need to be aware of what that means. Now, that's the total of the hydrogen and methane gas. So here's the take home on that one. So prior to 2017, there was a North American consensus paper on breath testing, and it was common to report a positive result for SIBO with a rise in the combination of both of those. Now, since that time, they're saying that that the consensus did not offer guidelines for the combination, so it's become a little ambiguous. And basically, why they put that on this particular test, which I'm glad they do, it's mainly for the clinicians' purposes to take a look at that. So just so you're aware, this was after 2017, that they will list these numbers, but they won't say yes, it's positive for SIBO or not. I'll explain why on an upcoming slide as well. But the main takeaways here are the hydrogen and the methane gas. So hopefully you've got that. All right. So review of what I just said. Okay. Evaluation of hydrogen. There's a rise of hydrogen of greater than 20 parts per million over the 90-minute baseline, positive for SIBO. Now, I want you to remember that about 8 to 20% of individuals do not produce hydrogen due to the presence of what's known as these methanogenic microbiota. So there's methane-producing bacteria, that can grab the hydrogen and therefore give you lower results. So that's definitely something to keep in mind. That's why you want to do the hydrogen and the methane together, so you get a better picture. Now, this is the methane now. Now, with regard to methane as it stands by itself, there's been some controversy about it, but methane can be very helpful in the diagnosis of constipation, IBS, and also obesity. So it's a good idea to take a look at both of those. The take home here is if you have high hydrogen and high methane, odds are you got SIBO going on. Now, the carbon dioxide. So why in the world are they measuring carbon dioxide? You'll see it right here on the bottom. There's a little check mark that they'll put down there. So what does that mean? It indicates carbon dioxide is acceptable. If you had there was an X posted here, that means carbon dioxide went high, and that's going to mess up the results. That's what that means in regard to carbon dioxide, why it's on there. Because if carbon dioxide exceed acceptable levels, like that sample integrity is going to become in question, and the results, they're designated and they may be not reportable. So they're going to make sure that the air quality in the room was okay. There was no room contamination. That's why they do that. That's a really good thing to have that on your test result. So here's some additional information for the test. So the normal transit time for about 10 grams of lactulose. And by the way, the patient will be given a sample of lactulose. They'll mix it with water in the preparation. Go ahead and drink that for the baseline. And about 10 grams, it says here, of lactulose. And that's normal transit time. It's about 90 minutes. So that's how they tell transit time to the ileocecal valve from ingestion. Once again, there could be a false elevation that can be due to incomplete avoidance of high fiber foods. I'll talk to your patient about that. Here's one of the caveats here. If you get your test results back and there's low or no breath gases, and you're very high suspicion for your patient to have SIBO, that can be due to high hydrogen sulfide producing bacteria, and I have them listed here. If there's a high Escherichia, let's say E. coli, Shigella, Klebsiella, or Citrobacter, those can be sucking the hydrogen down because they will use that. So definitely keep that in mind. That's why I like to consider pairing a breath test with a stool analysis kind of as a backup. I just think it's worth doing both of those tests to really clear the gut, to give you find out what's going on, and give you a good course of action. Of course, you need to make a clinical decision, but I think it's just a winner pairing these two tests together. But that's just my opinion on that. So this is a sample of the 3-hour test. This is going to look at small intestine and also part of the large intestine. Because it's going for 3 hours, there will be 8 samples, or sample 1 all the way to sample 8 right here. And again, that's recommended for individual with a slower GI transit or time and constipation. And this is where the cutoff is right here from small intestine at 90 minutes and 120 minutes, in the other hour generally indicates what's going on in the large intestine. But this is a good test mainly to do, like I said, for slow transit time and for constipation. So you get a positive test result back. What are you going to do with this information? What's some of the core treatment? And I have it listed on the slide for you. That's certainly to treat the overgrowth. That makes sense to do that. Provide nutritional support, and you got to address the cause and look for the cause. Just treating it is not enough. Like, what's causing this problem? So you definitely want to eradicate the bacteria, antimicrobial therapy, pharmaceutical or natural. Of course, we prefer natural as much as we can. You want to look to restore gastric acidity, and if a patient has achlorhydria, then you're going to need to have the patient take some form of betaine HCl with their meals to help with restoring acidity. Definitely want to normalize intestinal mobility. Look for transient time. Again, you can use this test to double check transient time after a few months. It can be used for that alone, not necessarily for SIBO. You can give them the lactulose and see how they do after 90 minutes. If you got good, bowel time, good bowel movements, very helpful. Again, you can use natural pharmaceutical antibiotics. There's the betaine HCl with meals. If at all possible, to have them discontinue acid blocking medication, prescribing the right diet. They need to drink water. And I'll talk about low fermentable fiber. There's a thing called a FODMAP diet you may be familiar with. Low FODMAPs, I'll mention that, and I'll show you a list of those in an upcoming slide. Probiotics, definitely without prebiotics. You don't want to be giving prebiotics to patients with SIBO because it's fiber, and the bacteria are going to start to use that as food and create more gas and bloating for your patient. Stress management definitely goes without saying for the majority of these chronic, I think for all these chronic conditions. I'll just make a blanket statement. And exercise, it doesn't have to be vigorous. It could be Tai Chi, Qigong, relaxation exercises, meditation, prayer, all that works very, very well. Now, also, you have to think if your patient has had SIBO, irritable bowel syndrome, either C or D, odds are that they are nutritionally deplete somewhere along the line because of the nutritional consequences of SIBO and even other gastrointestinal conditions. Be some weight loss. There's going to be fat-soluble vitamin deficiency. Could be iron deficiency, low serum bile acids, low RBC folate, and a whole bunch of other malabsorption, maybe not absorbing protein, all kinds of things if they've had long-standing SIBO. So it's a good idea to think about doing what's known as the NutriVal test, which I'll be talking about later on this month, by the way. So you need to assess your patient and replete the deficiencies as much as you can to get their body up and running, get the machinery up and running, the functional, the biochemistry. The most common diets that work really well for this condition, by the way, there's 3 of them. One is the specific carbohydrate diet, the SCD, wonderful diet. So if you're not familiar with that, go ahead and Google that. It works very, very well. Low FODMAPs, I'll explain that on an upcoming slide. And of course, the elimination diet, which can be difficult for a lot of patients. I suggest looking at the first 2 and formulating a workable workable diet for your patients to be helpful. Now, that whole FODMAP thing, if you're not familiar with, you want to have these type of things low in the diet. So what are FODMAPs? Fermentable, oligo, di, monosaccharides, and polyols. So what are they? They are carbohydrates that are found in a diet, and they're generally not digested or well absorbed. But the bacteria love them and can cause abdominal distress and bloating and gas and all that kind of stuff. So you want to have your patient on a low FODMAP diet. And I have a list of some foods that are associated with a lot of those fermentable oligomonosaccharides and polyols listed here. Like, hello? Okay. So I thought there was a break in there. So most foods associated with that, fructose containing, you need to avoid some fruits and honey. Certainly high fructose corn syrup shouldn't be on anybody's list, not only because of what it does to the body, but there may very well be some toxins in there as well. Lactose containing dairy, stay away from dairy. Fructans, you're going to see that in wheat, garlic. I believe that should be onions, by the way, inulin, and legumes, and the polyols, that's your sweeteners. Mannitol, sorbitol, xylitol, and some of your stone fruits as well. So it's a good idea to look at that specific carbohydrate diet that I talked about, because it won't have any of these in there, and it makes life easier for everyone. So, and you want to get to the core treatment, like I talked about. What's going on? Are they been on acid blocking medication? Is that it? Is there hypochlorhydria? Is there hypothyroidism? Review the slides that I put early on in this webinar for those risk factors. And is there diabetes going on? Nerve involvement? Pesticides, by the way. I want you to think of pesticides as neurotoxins that can slow down transient time. Just think of it. They're neurotoxic. They're toxic to the bugs, and they're toxic to the nervous system. Is very susceptible to that because they're neurotoxins. So is detoxification a good thing to do eventually on your patient, get to the root cause? Yeah, I believe so. So getting close to the end, I want to talk about, by the way, at Evexia, I'm the Director of Clinical Support and Education at Evexia. Very honored to do so. I love doing this work. I love answering blood chemistry questions. And Evexia this year, they have a wonderful supply of nutraceuticals that I'm just so glad they're doing that, because these have been researched, and that's really a good thing for quality as well. So there's some that Evexia, they have a whole list, so I suggest you check with that, but some that are specific for SIBO that can help your patient if you decide to avail yourself of these are listed on the slide here. There's one that's not on the slide, so I'm going to start with the one that didn't make it to the slide on there, and they have a supplement that is it's called Gastro Microbe Essentials. It's not on here, but please make a note of that. That's the one that has the natural antimicrobials in it, the wormwood, black walnut, and also the berberine. That should have made it on this slide. That may have been me. So the next you see here, just going from left to right, is Gastro Balance Plus. That is good for heartburn and bloating. It's got DGL licorice and it's some mastic gum that can be very helpful. And then there's Gastro Plus. That has the L-glutamine in there to help repair the GI lining, zinc carnitine, all those stuff that you probably know about, and the D-zymes essentially to help out with digestion. That's the one that contains the betaine HCl, and over all the way to the right is liver gallbladder. If you have an individual with gallbladder problems, they're not producing bile or even some bloating properly after meals, that's a really good one. It's always good to clear the liver and make sure the liver and for detoxification and the gallbladder is working functionally, or at least bile is being taken out of the liver properly. So later on in this month, I'm going to be doing the webinar. If you can, we'd love to join. We'd love to have you join us. And that's applying the NutriVal test in clinical practice. And I like this one. I like all of these, by the way, because I love doing this kind of work. It's wonderful. That test is great to take a look at the nutritional status of your patient. They don't have to be very sick, but you're looking at getting them functionally better, getting the biochemistry better for nutritional deficiencies. You can even use this to look at to help with athletic performance. So I won't give all the bullet points away here. But if you want to, it's going to be on May 30th. Please join us. So I'm finished for this evening, but I will answer some questions if you all have any. Next, I'm going to turn this over to Michelle. She's going to tell you how to order the SIBO test, and then she's also going to tell you how to contact. And Michelle, just let me know when to hit the button for the next slide for contact information. Thank you so much.
Thank you, Dr. Sedano. everyone, as you can see from this slide, it's quite simple to order this test right from your account with Evexia Diagnostics. Step one, as you see, is to simply go to the home page and log on to your account. And then you can actually click on the test menu link once you are in your account. And you will see search the Evexia Diagnostics test directory. This is a great way to find SIBO test and really any of the kits that Evexia Diagnostics has to offer. You can just type in SIBO, SIBO, and search, and it pulls up some great basic information about the test, what you need to do to, get ready for the test, and then actually, if you see the arrow pointing to the green, you can order the test right from that page, and it will bring you to a section that will have your address information already filled in there, and you just enter in how many you want of the test, and then you go ahead and place the order. We'll take care of it on our end, and as you folks probably know, you aren't charged for the SIBO test until that's actually sent back to the lab, and that's the point that you will be charged. So it makes sense to maybe have some of these in stock for you, so that you can be ready when someone comes in. Dr. Sedano, again, thank you. We don't have any questions at the moment, but everyone, please, if you think of anything after the presentation is over, feel free to contact myself or Dr. Sedano. We'll be happy to help you.
And Michelle, I just clicked on the last slide here.
Yes, I see that, Dr. Sedano. Thank you. So everyone, you can contact us right at the website. Certainly through Ask the Doctor, as Dr. Sedano mentioned, and you can contact me, and you can dial the 888 number and speak to client services or ask for me. Thanks, everyone. Have a good night. Have a good evening, Dr. Sedano.
You too. Thank you so much.
Thank you. Oh, Dr. Sedano, are you still there? Nope. Okay.